mic test. Mic test, hello. Hello, good evening. Wait. YouTube chat. Wait. Ito. Okay. Okay, I just realized that my streams... on YouTube, my stream is scheduled at 10 p.m. I don't know why. I know I set it at 9 p.m. Hello. Or is it at 9? Is my stream scheduled at 9? The YouTube? Because on my end it says 10 and I don't know why. Does it say 9? Did it notify you guys at 9? Cause I don't know. Wait lang. It says 9. Okay. I don't know why on my end it says 10. Weirdohan ako. It's like I'm living in Japan or something. Anyway, good evening. Hello. Supporters. Hello. Welcome to the stream. I have not prepared any slides for this. Because I didn't have time to prepare. No, actually, we're just gonna talk about intestinal volvulus. Okay, I mentioned it on Twitch. We're just gonna talk about one case, okay? And I'll just if I want to show you photos, I'll just use Google. Yeah. Timing ng eduk stream mo, Doc. Exam ko ngayon legal med. Lah! Anyway. I really didn't exactly have a good topic to really discuss for our last medical education stream. Like, I have... I think I've exhausted every, PowerPoint methods. So I'm gonna start with whatever interesting... So for medical education streams, whatever interesting case I have, or, anything interesting, I'll just talk about it on a medical education stream. So, Shrimsomnia, thank you for subscribing. Thank you. What was I gonna say? Yeah. So, since my Donathon on Twitch, my birthday Donathon on Twitch, when I got back to work, I got really busy. Like, really busy. I had a lot of surgeries to do. Like, most of them were breast surgeries, but, nothing that interesting. The interesting one is the one I had as an emergency case. So, the emergency case is, it was something of a life and death situation for that patient. See, that patient's actually pretty young too. I think he's like 20 something. So let's let me. Do I have my tablet? I'm gonna use my tablet. Wait, hold on. I should use a tablet, and we're gonna use. I'm gonna open up an MS Paint or something. Wala lang ha. I will use tablet, MS Paint. We will use Paint. Paint to write the details of this. So, wait. Let me just prepare. There we go. There. Okay. So, I will use a pen. Is it pen? Let me, What's this? This is crayon. Okay, we'll use a pen. Hold on. Okay, I use like blue. Okay. Good evening, card chaser. Good evening, good evening. Okay, let me bring out the window here. Huh. Oh. This is going to be really... Where will I put this? I'll put this right here on top. Okay. I'll put him up here. I'll put it up here, right here. Okay. Now, where is... This is my notepad. Okay? My notepad for this thing. So, we have a patient. So, this patient came in like a few days ago. I think, or this one came like... Actually, 4 days ago. On the night of, the day after my Donathon. Actually, he came at the day after. The day right after my my birthday Donathon. And he came in complaining of abdominal pain. So, he was really, really in pain. They brought him here and then, so he was, if I remember correctly, he was like a 20... let's see, he was a... Let's name him, let's name this boy, let's name the patient, patient... Let's name the patient, what do you want to name the patient? Let's name the patient, ano ba? Let's name the patient, boy. Patient boy. He was like, I think if I remember correctly, he's like 29 or 27. He's like a 27-year-old male. Okay. And then his chief complaint... Boy abunda. His chief complaint was abdominal pain, okay? Abdominal pain. Okay, he was complaining of abdominal pain. Actually, you know what? Let's go to the other window. Dapat pala sa kabilang window nila ako, no? Ito. So that you guys can see it a lot better. There you go. Thank you for subscribing, the Spectralist. Thank you. Okay, he was complaining of abdominal pain. Si Tito Boy. So, anyway, yeah, abdominal pain. Okay. Apparently, I think if I remember correctly, it was 2 weeks, I think? The history was history of present illness. It was a 2-week history. 2-week history of, ano tawag dito? Of on and off abdominal pain. Now, where in the abdomen, he would say it's at the center, so, you know, sometimes in charts, we would draw, like, the abdomen like this. We would draw, like, on the side notes of the chart, we would draw like this. If this was the abdomen, we draw the abdomen like a piatos. See, this is your abdomen, and then we draw a little belly button there. Like a little piatos. And then, because if we divide the abdomen into, like, 4, so that's 4 quadrants, so it's like, it's 4 quadrants. Oops. No. Okay. Like this one right here would be this would be the right upper quadrant. This would be the left upper quadrant. This is the right lower quadrant. And this is the left lower quadrant. Left lower quadrant. Okay? So he would say his pain was around here in this area. Like on the upper abdomen. So parang sinisikmura there. He would say parang sinisikmura. Okay? That's where the pain would come. And when you probe him, he would say, I would ask him, usually because if you have pain here in the center, you would think, oh, maybe he has ulcer. He has ulcer, right? Stomach ulcer. So I asked him, do you drink a lot of coffee? And then, according to the relatives, he does drink a lot of coffee. So apparently he drinks, sabi nila, 10 cups of coffee a day, bro. 10 cups of coffee per day. How I don't know how he does that. That's very painful. He drinks 10 cups of coffee a day. So please, guys, do not drink 10 cups of coffee a day, okay? He also likes to drink energy drinks, okay? So that includes, ayan, he likes to drink, Sting. He likes to drink Cobra. You know, energy drinks. Basically energy drinks. And he drinks them like almost every day. Okay? Every day. And I told him, like, bro, I drink energy drinks. Monster nga iniinom ko. Ba't araw-araw mo iniinom yan? I'm like, I drink Monster. Mahilig din naman ako sa energy drinks. Umiinom ako ng Monster, pero hindi ko naman inaaraw-araw. Like, actually, to be honest, I like Monster, but the last time I drank Monster was last month. I still have a can of Monster in my refrigerator, which I haven't touched, so... I only drink energy drinks if I feel like I need it. So, I have not taken any energy drinks for the past month, actually. This whole December, I have not drunk any. So, yeah, so, you know, with this kind of history, this past medical history, this right here, I was starting to think, you know, he probably has peptic ulcer disease. Peptic ulcer. That was the first thing I was thinking, right? Peptic ulcer disease that perforated. When you say perforated peptic ulcer disease, it's when your stomach gets a hole. When your stomach, when you get an ulcer and it ruptures and you get a hole. I don't know how to draw a stomach. Let's see. Can I draw a stomach? Let's draw a stomach. Intestine. Let's not use this ink. Let's not use that ink. Let's draw the stomach as let's draw the stomach to be pink. This is the esophagus, and then yeah. Okay, stomach! Alright. When you have an, let's say he has an ulcer right here. Ulcer. The ulcer. If it perforates, get a hole, let's draw a little hole. Perforation, you have it means the air or whatever's inside spills out into your abdomen and it shouldn't happen. So, this is a perforated ulcer. Usually, when we have this kind of case, what we do is, these kinds of cases where you have a perforated ulcer, or pag nabutas yung tiyan mo, these are considered emergencies, okay? This is a emergency. We call this PPUD. Perforated peptic ulcer disease are emergencies, okay? Emergency. Surgery. You need emergency for this. This is the kind of patient that you have to send into the operating room right away. So, when I got this patient, I was thinking, he probably has a perforated ulcer. So, usually how we find that, okay, we're gonna go to, perforated peptic ulcer disease. We got a lot of... Okay, I'm gonna look for photos, okay? Oh, this is a nice photo. This, we got a nice photo over here. We got a nice photo here. There we go. Perforated peptic ulcer disease. Okay? See that? Well, this one is actually bleeding. So one on top is perforated and the other is bleeding. You can have, like, you know, whatever's in there just spills out or you just bleed. This is a true emergency. So usually, how do we find this? How do we detect this? To confirm, I mean, we usually go for a chest X-ray. So Google. Okay. Chest X-ray. Usually in a chest X-ray, you would find pneumoperitoneum. And I'll show you what a pneumoperitoneum is. Pneumoperitoneum means air in the abdomen that shouldn't be there. So here we go. Look at this. I wish this is a normal chest X-ray, okay? I'll show you first what a normal chest X-ray looks like. So we have this as a... this one. Yeah, this is a nice normal chest X-ray. I'm gonna post it here on this page I have. And then I will show you. So this is a normal chest X-ray, guys. Now if you have pneumoperitoneum, there is air, okay? So, what is the most obvious one? Oh, this is the most obvious. This is the most obvious one, yo. It's here and then. Okay. Let me show you guys. Okay, guys. Now let me show you a normal X-ray, okay? Let's use Is this a marker? Oh. Let's use a paintbrush. Alright, this is a normal chest X-ray, okay? So this one right here, this is a normal chest X-ray. This right here, you see this? I'm gonna draw this. This is the diaphragm, okay? This is the diaphragm. It's a muscle that separates your chest from the abdomen. So these are your lungs, heart, okay? This one right here is your trachea, so trachea. Okay? So this is a normal chest X-ray. And then down here, you see these gassy stuff here. This is the intestines. Sometimes you see the stomach there. Okay, the stomach is here. You'll see like a gastric bubble or something. It should be like something like that. This one here, the solid part, that is the liver. The right side of the liver. Okay, so this is a normal chest X-ray. If you have pneumoperitoneum, this means air inside the abdomen and should be there. So this is one severe example. Look at this. This over here, the second one over here, this is the diaphragm. Okay, it got elevated. This is the diaphragm. You can see the lining. Okay, here. This is the lungs. This is the heart. Okay. The trachea. Okay. So you see this space here? This space, this black space that separates the, okay? This is the liver over here. This is the liver. This is the stomach or probably intestine. This space here is air. And it shouldn't be there. Okay, this is like a really severe case. So we usually order a chest X-ray so we can see this. If we see this space, then it's pneumoperitoneum and he needs surgery. The one here on the rightmost is like a smaller, but you can see there the diaphragm's right here. You see that? There's like, and then you can see like a small space in between. This one right here. This one. This one right here is a small space. Right? That's air. You can also see it here. There's like a little... oops. You can actually also see it here. This is the diaphragm. And then you can see like a little tiny bubble of air. Okay, that's also pneumoperitoneum. If you see this and the patient's complaining of severe abdominal pain, that's an emergency. Okay? So, for those who are medical students... Oh, that reminds me. You know, I've come across some younger residents, junior residents, that don't know what pneumoperitoneum is, and I'm pretty sure they're supposed to teach you that in med school. Okay, are there any med students here right now, or any like who are still residents or something, or interns? You guys better know what a pneumoperitoneum is, okay? I'm telling you guys. If you see a pneumoperitoneum like that, if you see this on a chest x-ray, pneumoperitoneum, okay, you better... And the patient is in severe pain, like abdominal pain, you better refer that patient to surgery ASAP, okay? You have to refer that patient to surgery as soon as possible. Don't even wait for an official x-ray result, okay? Wait for the radiologist to say, to like make a printout. Okay, as soon as you see the image and you see something like this and the patient you're handling is complaining of abdominal pain, please refer the patient to surgery as soon as possible, okay? And $2. Thank you for the $2. I think that's Dianjo. I'm pretty sure that's Dianjo. Thank you for the $2. Thank you. Okay. So, alright, I'm telling you guys, med students or future med students, okay, I'm telling you right now. So you can say, what happens if you see air in the x-ray and your patient is complaining of abdominal pain. Okay, refer to surgery. Oh no, wait, did I get disconnected? Hello, am I back? Did I get disconnected? Okay. Hello, Doc, it's my first time watching your stream since I'm a busy pre-med student. Thank you for the educational stream. Okay, no problem. Hi, Doc, sorry if I missed it, but how does pneumoperitoneum occur in the first place? Okay, yeah. One of the surgical causes, like I was saying, is a perforated ulcer. So, I'm a surgeon, okay? So I'm telling you the surgical causes. Okay? PPUD or perforated peptic ulcer disease. This is one of the causes. One of the most common causes I've encountered that causes pneumoperitoneum, especially if they are in pain. Okay? They usually peptic ulcer disease that gets worse and perforate and develops a hole or a perforation and the air comes out. That's what happens. Whatever's in your stomach spills out and it's not supposed to do that. Okay? So if you see something like this, there are some cases of pneumoperitoneum, or where you have air in your abdomen where the patient doesn't even feel anything. Sometimes they have air. Like, they have air in their abdomen and they don't feel anything. They're not in pain. Their vitals are stable. They just have that air there. Those kinds of patients can be treated conservatively, or you don't need to do surgery. Sometimes, maybe those patients just had surgery, that's why they have the air there. If a patient just had surgery, especially in the abdomen, they would normally have air inside the abdomen. That's normal. Because you open up the abdomen, and then the air just goes in, and then you close it, so the air stays inside. Okay. Sounds like a rough night. Yeah, this is what I suspected for this patient, okay? So this patient, as I was saying, he's a 27-year-old patient, male, complained of abdominal pain, and then the relatives would tell me this. He had 10 cups of coffee a day. He drinks Sting, Cobra, energy drinks. I'm like, Holy shit, man! What is this guy doing with his life? So, are there instances where it disappears? So, yes! Especially if the patient's stable, okay? But this one, we're talking about surgical emergencies. So, as long as you see this, okay? As long as you see pneumoperitoneum, and the patient is complaining of very bad abdominal pain, you refer that patient to surgery as soon as possible. Do not wait for the radiologist to tell you. I mean, it's kind of obvious. I mean, if you know how a normal chest X-ray looks like, you will know how a pneumoperitoneum, and then you just need to know how a pneumoperitoneum looks like. You can't miss it. Although there's some people, some residents who do miss it. But there, I'll show you guys. Wait, let's go to the browser. Here, look at this. These are all chest X-rays of pneumoperitoneum, so you can see. Okay, you can see. Look, see, this one has a space over here. This one also, you can see, they have space. You can see the diaphragm. They all have that space, okay? The X-ray that you order for, that you request, has to be an X-ray where they are sitting upright or standing up, okay? Because if they're lying down, you won't see that. But, you know, it's kind of obvious you can see. Okay, that's a pneumo. Sometimes you might have a stomach that has air here, like chest X-ray, like for example, it might look like pneumoperitoneum, but it's not. And a lot of this happens. Like they would refer, on the other hand, they would like refer to surgery because say, "Oh, my pneumoperitoneum. There's pneumoperitoneum. There's pneumoperitoneum." Like this one, like this right here. They would say, this one is pneumoperitoneum. Okay, yeah. They would say like, this one is, oh shoot. Oops. They would say this is pneumoperitoneum. Pneumoperitoneum. That's not pneumoperitoneum, okay? That's just the stomach that has air inside. That's a gastric bubble. It's called a gastric bubble. It's just the stomach and it has air inside. That's what it is. So how can you differentiate this from pneumoperitoneum? All you gotta do is, what I do is I look at the other side. Okay? It's a stomach bubble. They just call it gastric bubble or stomach bubble. I look at the other side because if you have pneumoperitoneum, you would see this kind of air on the other side of the X-ray, like over here where the liver is, because that's not supposed to be there. You would expect some air here because the stomach stays here, and the stomach always has air. On the other hand, on here, you have the liver, and the liver is not supposed to have air, okay? So, that's one difference. Because if you look at the other X-rays, this one is no, this is gastric. This one is pneumoperitoneum. They have air on the right side. See, over here. So that's one way to differentiate. Okay? Is that the medical term for kabag? I think kabag is like, feeling bloated. And no, it's not. This one is pain. Kabag is like feeling bloated and full and, you know, not really exactly. The pain is different. For some reason, it makes me imagine that once you cut into them, since they're full of air, the incision just farts. I haven't had that. I haven't experienced that. Anyway, I have not experienced that of farting when you were doing the operation. Okay, anyway, let's go back to the paint. Here we go. Right. So, let's continue with the case. So this is what I thought. Okay, so he had abdominal pain. So what did he do? He had a checkup. He went to another hospital, where they looked at him and checkup in a hospital. So, they checked him in a hospital, they worked him up, they did a CT scan, okay? CT scan. if I remember correctly, his CT scan actually didn't have shit in it. Nothing. Didn't say anything. CT scan was unremarkable. Unremarkable. Like there was nothing, if I remember correctly. There was no air. Okay, there was no air. This is negative. Negative pneumoperitoneum. Negative pneumoperitoneum. I think negative for acute appendicitis, which is weird for me. So this was weird, man. There was basically the CT scan didn't give us any shit. It didn't give any information about what's happening in his abdomen. But one thing's for sure, when he came to us, he brought all that stuff, the laboratories and the CT scan. He came to us looking really pale, so he was like pale and really in pain, in severe pain. And then, if I remember correctly, his vital signs were very bad. His blood pressure was like 80/40, I think? Very low. Normal blood pressure is supposed to be like 120/80, right? So his was 80/40. And then his heart rate was like at 150s. Normal heart rate is 60 to 100 beats per minute, okay? And then he was breathing really fast, so around 40s. And then I think, if I remember correctly, he did have fever, so his temperature was like 30. I think it was a 38 point something, 38.8 or something like that. Okay. So he was unstable, and he had his abdomen was rigid. Okay, abdominal examination. Okay, his abdomen was rigid abdomen. This is something, if any med students there, the rigid abdomen is kind of hard. It gets a little tricky for you to feel this, because when you feel, if you're a med student or a pre-med student, the only way you'll be able to really master PEE is to really practice it. You have to be able to differentiate soft abdomen from rigid abdomen. Okay, so his was rigid. When I say rigid, it was like a freaking board, like that hard, man. well, when you tap on it, it doesn't sound like that, but you know, it's when you push on your table, his abdomen was like that. It was something like that. It's not soft. I mean, if you're not in pain right now and you poke your abdomen, it's soft, right? His was hard. Okay, his was firm, rigid. Ouch, rigid. So rigid abdomen with tenderness all over. When you say tenderness all over, it's like when you push on it, it hurts. Anywhere you touch, tenderness. This is our terms in the medical field. Rigid abdomen with tenderness on all quadrants. On all quadrants, okay? Sometimes in between, if med students will do medical students and interns do a really, really complete physical examination. This is the fun part when you're in a medical field. You know, the younger you are in the medical field, like you're a junior intern. Junior intern. Like the lower you are, if you're a junior intern, you take your medical histories really detailed. Like when they interview a patient, it takes so long. They could take like 30 to 45 minutes because they take every detail. They would like, they take like 2 weeks prior the patient developed abdominal pain, and then 13 days prior the patient, and like it's a really whole ass paragraph. And then when they do a physical examination, they really do everything, like from head to toe, even doing a neurological examination when it's not even needed. And then they even, if you've been in a government hospital that has med students, med students, and then they interview you, right? They even ask like your where's your house? What is your living condition? Do you have a lot of mosquitoes in your area? Do you have how's your water? Where do you get your water? Is it Maynilad water, or do you just get water from the well? They do that. That's a junior intern way of doing history and PE. And it's also like that when you're a senior intern. They do that. Like super detailed. The higher you go, like after senior resident, your history gets shorter and shorter until you're like a fellow and a consultant. So yeah, they do a really long case, but the higher you go, you just start to pinpoint, okay, this patient is complaining of abdominal pain. Then you focus your everything on abdominal pain. But if you're like a med student, an intern, you take everything. I used to do that. My history would take an entire page. But right now when I take history, just like 3 sentences and I'm good. Anyway, so tenderness in all quadrants. If we auscultated it, it would be like hypoactive bowel sounds. Let me put it here. Hypoactive bowel sounds. Meaning the sounds in the abdomen when you listen to it is not as active. They're slow. Okay. What else? Oh, and as soon as he got into the ER, we inserted an NGT, right? We put in an NGT. So we inserted an NGT, which is a nasogastric tube. It's a tube where you insert into the nose and it goes straight into your stomach, and we got like 1 liter of 1 liter of dark brown fluid. We drained that. And then his urine output, we put a Foley catheter. He only had like 50 ml of urine, and it was like really dark yellow. Urine, dark yellow. So, if you have something like this, urine dark yellow, and it's only a few, the patient's dehydrated. He's dehydrated. So, NGT, I'll show you what an NGT is, okay? Hold on. NGT. Okay, here we go. This is an NGT. Here. This is an NGT, guys. So, you might encounter this, like if you have some relative goes into the hospital and they say, kailangan lagyan ng tubo sa ilong. Okay, this is it, an NGT. It's like a little tube, a silicone tube or a plastic-ish tube that looks like this, or sometimes it looks like this one. What they do is they put it in the nose, because you see the mouth and nose connect towards the neck. So the nose and the mouth, they connect, they become one. They can connect into the esophagus. So you insert it through the nose. It goes down to the esophagus until it reaches the stomach. So the purpose of this tube is to drain whatever's in the stomach. Okay? Whatever's in the stomach, that's what it does. So we inserted that, and we got like a liter of brown fluid. I went through one of those NGTs. Very weird feeling getting out. Yeah, it's pretty uncomfortable putting it in, because imagine putting something inside your nose, okay? And then you're poking whatever's inside your nose until it goes all the way down to your stomach, okay? That's what the purpose of the NGT is. It can be used for drainage, or it can be used for feeding for people who can't swallow. Hey Doc, may I ask a question about my surgery which I had 10 days ago? Well, it depends on what kind of surgery you had. Do intestines and other organs in the abdominal region reorient themselves after surgery? Oh, yeah, like if, for example, we pulled out the intestines and just placed them back. Yeah, they do. Konbanwa! Hello, Kay! Konbanwa! Good evening. Genuine question, why does it have to go through the nasal cavity? Because the reason why is because people talk with their mouths, that's why. Imagine having a tube in your mouth and you're trying to talk, you're just gonna end up spitting the tube out. You know, that's why. That's why it goes through the nose. Imagine having this in your mouth, okay? And then you're gonna start talking to the doctor, and then you spit out the tube. Okay? That's why it goes through the nasal cavity, alright? No, not all patients are asleep, man. You insert this while they're awake, because what they do is you put it inside and you instruct them to swallow, because once this tube goes to this area, they have to swallow so that it goes to the esophagus. Sometimes this tube ends up in the trachea and goes to the lungs, which you don't want that to happen. When it does go to the lungs, it's super uncomfortable, so yeah. So that's why it goes to the nose, okay? So, probably the only time a feeding tube like this goes through the mouth is if it's a baby. We call it an OGT. So, if it's a baby, if the patient is a baby, then it goes through the mouth. Because anyway, babies cry, you know? They just cry, they don't really speak. They just like, wah, 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 and then, you know. And because, it's bigger. Alright. Now, alright, so back to the case. So after that, I saw all of this, we did all of this, right? This is me preparing the patient preoperatively. So after all that, I found it weird. I requested for an x-ray because I was really thinking, this guy probably has a perforated ulcer. Okay, he probably has a perforated ulcer. So I'm like, we need to operate on this guy. Okay, we need to operate on this guy. So I had to prepare him, like, you know, hydrate him, give him antibiotics, and, you know, refer him to an anesthesiologist. Considering his condition of having really shitty vital signs, like his BP, his blood pressure did not go higher than this. His blood pressure did not go higher than this. I think it got even lower. Like, right before the surgery, he went down to like 60/40s, which is super low. That was really, really low. Okay? That was really low. And considering that his vitals were really, really low and like this, he was in pain. He was really hard-headed, okay? He would be in pain and he would like be angry at his relatives. Sakit ng tiyan ko, blah, blah, blah. But then, I would be like, hey, you gotta calm down. You're gonna prepare you for surgery, and I really think you have a perforated ulcer, okay? And we need to confirm that with a chest X-ray. But your chest X-ray was taken while you were lying down. We need one where you're sitting up. And then he just told me that he needed to take a poop. He felt like pooping. He said that. Para, natatay ako, doc. Natatay ako, doc. I'm like, I'm like, yeah, you're wearing a diaper. You're wearing a diaper. Just do it there. And he's like, ayoko. Ayoko sa diaper. I'm like, where do you want to poop then? I'm like, gusto ko tumayo at pumunta sa banyo. I want to go do my business in the bathroom. And I was looking at him like, yo. Like, no, you can't do that. You gotta do it in a diaper. It's like, ayoko. I don't want to do it in the diaper. I don't want to do it in the diaper. I'm like, why? Like, I don't want to do it in a diaper. And he's like, I want to stand up and go to the bathroom. And he was like ready to get up. I'm like, no. No, you gotta stay there. You gotta stay there in a bed and poop in your diaper because your blood pressure, I'm like, your blood pressure is 80/40. If you stand up, you're gonna get dizzy and you're gonna fall down, okay? The nurses have to watch you. And he's like, no, kaya ko to, doc. I can do it. I can stand up. And he's like, kaya ko to, doc. I'm like, really? Kaya mo? Kaya mo? And he's like, yes, doc, kaya ko. And he gives me this determined face. Like, kaya ko, doc. I'm like, really? Bakit? Hindi ba masakit yung tiyan mo? Hindi ba masakit? He's like, hindi na, doc. Hindi na masakit yung tiyan ko. I'm like, he's like, my... I was like, talaga? Hindi ba sakit yung chan mo? Sige nga, kapain ko yung chan mo. Let me feel your abdomen. So I tell, higa ka muna, pakapain ko. And then I feel his abdomen again. And it was still hard, okay? Eto, masakit ba to? And then he goes like, well, hindi, Doc. Hindi, Doc, hindi masakit. And his face was like, flinchy. I'm like, and I looked at him like, masakit siya. Huwag ka na magsinungaling, masakit na to. Like, you're in pain, man. You're in pain. No, don't even try to hide. I can see it. It's all over your face. You're in pain. Yeah, like, you stay in the bed. Even the nurses were getting pissed off with him because he was, like, getting really stubborn. They were, like, getting angry at him. Like, oh, sir, baby mo. Ganyan, bumaba ng 60, mahihilo ka, matutumba ka. Ganun. Oh my god. Well, anyway, yeah, he was really stubborn, but eventually we got him to the OR. Okay, we got him to the OR. And we opened up the patient, and I was thinking I was gonna see a perforated ulcer disease, but no, I saw something else. Okay. Wait, what's this? The surgery was a beltectomy. Beltectomy? I have drains that leak outside. I use gauze to stop the drainage from hitting my clothes. Any way to prevent that or just gauze? The fluid still goes to the bottles attached, but any way to prevent it from leaking? Bottles? Beltectomy? What was removed? What do you mean a beltectomy? I haven't heard of a beltectomy. I have not heard of a beltectomy. What is a... Oh! Is this a plastic surgery? Ah, okay. Is this a plastic surgery? I think it's a plastic surgery. Okay, yeah, it's a plastic... Okay, this is a plastic surgery. That's why I haven't heard of it. I'm not a plastic surgeon. Okay. Okay, you probably have Jackson Pratt James. You know what I do? What I tell patients that have leaks, they leak through the incision, right? Is that where they leak? They leak through the incision, where where the tube is. Is that where they leak out from? They leak from where the tube is inserted. You know what I do? So that it doesn't go to your clothes right through incisions. Okay. What I do is, you know what you can use? You can actually use napkins, man. Sanitary napkins. You get a sanitary napkin. Like, choose the brand of your choice, man. Choose the brand of your choice of a sanitary napkin. You cut it, make a slit on the napkin, and then use that. That's where you like, here, I'll show you. I'm gonna draw a napkin, guys. Let's draw a napkin. Okay. Got it, sanitary napkin. Sanitary napkin. Sanitary. You just cut it through, cut it in the middle. Yeah, cut it here. Or make a little Y. Okay? And then, the pad side, you know, the side of the pad, that's what faces your skin. And then, the tube, you just slip the tube through the slit, okay? This is the tube. Tube, and then I think you have like it's a little grenade. Like a little granada. Okay? Just tape the napkin. The napkin can absorb the fluid, okay? That's another purpose of the sanitary napkins. Alright? That's one way. Okay, that's one way. So that doesn't get to your clothes. Okay? That's one way to do it. That's what I do. Because if you use gauze, sometimes they seep through the gauze. Especially if you have a lot. But if you use sanitary napkins, they can at least catch more. Okay, that's one way. That's one use of the sanitary napkin. That's what I tell patients. Like, if you want a cheaper way of doing that, you know, instead of just changing all the time, use a sanitary napkin. They can catch the fluid more. Okay, Just make sure the sanitary napkin's clean. Okay? Alright, napkin lang pala katapat niyan. Sana malaman kayo when I had my it's like an alternative, man. It's an alternative. It's a cheaper alternative. You can just buy like a pack of napkins and then use that. Hello, welcome. Alright, so we opened up the patient, okay? So we did an exploratory... Our surgery was an exploratory laparotomy, okay? Emergency exploratory laparotomy. Okay? This is when you, an exploratory laparotomy is when you... Okay, example, this is the abdomen. We draw the abdomen like a piatos, right? We open the abdomen in the middle like that. Going around the umbilicus. Okay? That's how we cut open the abdomen. And I was expecting to find a perforated ulcer, but no. I did not see a perforated ulcer. And the first thing, you know, when we cut open the abdomen, the first thing that came out from there, I was expecting like air and gastric fluid, but what actually came out once we got into the abdomen, what came out was freaking blood, man. Old blood, the like bloody fluid, which kind of alarmed me because if in a perforated ulcer, the fluid is usually yellowish or sometimes it looks like pus. But no, this was like bloody fluid. So I saw bloody fluid, like a lot of it, and I was like, what the hell? Why is there bloody fluid? That means it was something else. I'm like, this is not gastric ulcer, guys. I was like, oh no, guys, this is not gastric ulcer. Gastric ulcer does not look like this, man. The fluid of a gastric ulcer is not like this. I was like, what the hell is wrong with this guy? What does this patient have? Okay, what does this patient have? And then, after we opened it, you know, first thing we saw when I was open, so I started to open all the way. So we drained all that bloody fluid. And then what I saw next was like and it started to smell. It smelled bad. I was like, what the hell is that smell? And then as I opened the abdomen, I saw freaking black fucking loop of intestine, okay? It's a fucking loop of intestine, something like that. It was freaking black, man. It was a black intestine. A black loop of intestine. Like, make it bigger. Like, it was big and swollen black intestine like this. And then the rest of the intestines were pink. And then you have, like, the rest of the intestines were, like, pink. Like, yay, pink intestines. We're alive. Live intestines, wee. And then you have this black one. And it smelled so bad. Yes, it was gangrenous. I was like, what the fuck? Hello, Alfiner, hello. I'm like, what the fuck is this? I'm like, what? And I was like, so this is what's causing his pain. It was a freaking loop of intestine, a small intestine, okay? That, a loop of small intestine that, twisted. It twisted on themselves, like, you know, twisted. You know, when you know, like, when you twist rope together, you know, if you have, like, a piece of string or a piece of rope and you twist both ends together, this end and this end together, you would have like something like that, right? When you have rope, that's what happened to the intestine. The freaking intestine twisted on itself. Parang magtwist ng wire sa ear. Yeah, like, this is a loop of intestine, right? Just loops twisted like that. So the twisting happened here. So basically his intestine twisted onto each other. And the reason for that, that's not supposed to happen. The reason for that twisting is because there was a stupid, there was something here, like a band or some shit. You call it an adhesive band, like an adhesion, that freaking caused it to twist around. And when it twisted around, it cut off the blood supply to the intestine, and the intestine, this loop of intestine died. It was black. Okay, it was freaking black and nasty. It smelled bad. It was gangrenous. I'm like, so this is what's causing this pain, yo. I was like, what the fuck? I'm like, they did not see this in the CT scan. Why not? Like, why didn't they see this? Okay. So, what did we do for... So, I'm gonna show you guys... We're gonna look for images, okay? This is gonna be, like, gruesome images. This is gonna be gross images. So, let's see. Intestinal ileal. It was a small intestine. Specifically, it was the ileum. So, ileal torsion. Or ileal volvulus. Oh my god, it's all freaking censored. It's censored, volvulus. It's called ileal volvulus, okay? Alright, we're gonna look at some gross pictures right now. We're gonna look at intestines, okay? Ileal volvulus. Oh, here we go. This is a perfect example of how the freaking twisting of an intestine looks like. This is a perfect example. This one, not this one. There we go. This is a good example of what, it's just a drawing. Okay, we're gonna see some intestines, okay? Alright. This one right here, yo. Okay, here, this is a good, example of, what I was saying. This one. There's like a piece of adhesion and it caused twisting and shit. Okay, that's what happened to his intestine. Alright? And then, yeah, see the intestine. Actually, all these intestines you see, these are pink and red. These are still okay. The one I saw, these are all still pink and red. You know, slightly purple, but this one looks like it's still alive. It's just slightly pink. The one I saw was freaking black, man. Black gray. Black gray. It was, is there one? Let me see. I'm gonna see if we can find one. Hold on. Intestinal, torsion. You can say torsion or intestinal volvulus. Oh, okay. The gross ones are censored, yo. Let's see. Let's look for one. They censored the black ones, yo. Let's see. Okay, I found one. I found the closest one. Would be this. Okay, this is gonna be a kind of gross, okay guys? This will be a gross one. Okay, but this is how it looked like. Alright, here we go. Here we go, guys. Oh, oops. Oopsies, wait. Why is it not showing? Okay, there we go. There we go! It's black! This is how it looked like. It looked like this. It was black. And then you can see here, this one's like the normal color. The pink, light pink, or a pale pink. His was black like this, and it smelled bad. Okay? That's how it looked like. Okay, that's how his intestine looked like. It was just disgusting. Legit looks like burnt longanisa. Actually, yeah, come to think of it, it does look like burnt longanisa. It does look like longanisa that was burnt, but yeah, that's how his intestine looked like. The one here in the middle, the light one, that's the normal one. Okay. Alright, So, what do we do to patients who have that? So, I thought it was ulcer, right? I thought it was ulcer. If you had a gastric ulcer, all you gotta do is just repair the hole. You just drain whatever's spilt inside the abdomen. You just drain it, wash. And then, in an ulcer, all you gotta do is, like, if it was a stomach ulcer like this, all you have to do... The surgery for this is pretty simple. All you have to do is just, like, you just need to repair it. All you have to do is just close the hole. You just close the hole, or you can just plug it with a, you know how there's this thing inside the abdomen called the omentum, which is called the policeman of the abdomen. Okay, the policeman of the abdomen. It's an omentum. Omentum is like a dress of fat or a skirt of fat. You just put a piece of omentum on top of it. It's like a freaking, it's fat. Then the stomach has it, like it's like that. It's like a little dress of fat. You just put a piece there and then suture it together. That's how you repair that, and that's it, and you're done. That's it. That's how simple it is. But when you have something like this, okay, when you have something like this, let's draw a more proper one. Okay, let's draw a more proper one. I'm gonna draw some intestines here. So first we'll let's say we have some intestine like these. And then it just closes up together like that. And then you get the black loop. You get the freaking black loop right here. Black loop of intestine. Okay. And then there's a freaking band right. There's like a little band here or something. Yeah. Okay, and then after that you have another loop again. Normal intestine of like that. And then this is just black. Okay, this is just all black. Freaking black intestine. It's black. Longanisa skin is omentum, right? Longanisa skin? No. Why was the band there in the first place? I actually don't know. They just so happened to have that. Maybe he was born with it, or you don't know why. They just happen to have that. They just happen to have that. So what do we do in something like this? So this surgery gets more complicated. So what we have to do is, if this intestine was not black, if it was still pink, all you have to do is just release this band here. All you have to do is just release this. Just release this, release. And then untwist the intestine. Okay? And then you're good. If the intestine was not black, it has to be alive. If the intestine is still alive, slightly purplish, but when you release it, it turns pink, that means it's still alive and it's good. You don't need to do anything else. You just need to release this stupid band that caused everything. Now, what if it's black? You can't leave this inside. That means you can't leave this. You can't leave this intestine inside. This is dead. Okay? This is a dead intestine. Dead. So it's dead inside. You have something dead inside your body. You can't. You have to take it out. That means what I had to do was I had to resect it. But I had to resect it. So what I did was I had to close the other ends of the intestine. So we get an intestinal. Cut it off. Yeah, you have to remove it. Thank you for the sub, Big Jimbo. So I had to get a clamp and close this off. We had to close this off. Okay. To get a clamp and close this off. Okay. Close this off, and then we had to cut the. Well, when I close it off, we released this. We released this part, and then we untwisted the intestine, and then we had to cut it off. Cut. And then this whole thing. We took it out. Out you go. Out you go. Alright? And then the next step, so what you're left with is intestines that are clamped together, right? Like you're left with the normal intestines. You're left with the normal intestines, and then you have the clamp here. And then you have the clamp here. Okay, you have the clamp. You have the little clamp here, keeping them close. Because if you open it, the whatever juices are inside the intestine will just spill out. So you gotta, yeah. So what did I have to do? I have to connect them together. So what the next thing I had to do was, put these back together. Connect, which is a bowel anastomosis. So bowel anastomosis. I don't think I have a video on that yet. Anastomosis. I don't think I made a video yet on bowel anastomosis on my YouTube. I did suturing, but bowel anastomosis not yet. I should make a video on that. So basically, I had to connect those two together. And then what will it look like? It will look like a intestine. Okay. So I had to take that out and then reconnect the bowels together. So here. So I had to reconnect. What do you do with the stuff you take out of the body? So back here, we send this to the pathology department. They take a histopathology. They take a biopsy out of it. They make a biopsy out of it. They just study the specimen. Okay. So I will show you how a bowel anastomosis is. Let's see. Bowel anastomosis. Oh, here's one. Oh, this one is one. Oh, here's an example. Okay, here's an example of bowel anastomosis. How it's done. There is an easier way to do it. Through stapler, but I used sutures in this case. I used sutures, so I had to hand suture. Look, you just suture them together. So these are the ends of the bowel, the intestines, put them together. Cherry, thank you for subscribing. Connect with what? Dissolvable threads. It depends on your technique. It depends on the technique. So what there's like different techniques of suturing these together. Like there's this one technique called the Gambi technique where they use a silk suture, and it's only one layer and it's not an absorbable thread. I use a Connell Lambert, which is a two-layer suturing. The first layer I use is absorbable, and then the second layer is non-absorbable, or a silk suture. So there are different techniques. There's also stapler method like this, but this shit's expensive, and not all patients can afford it. So, but this would make it a lot faster, actually, the stapler. But yeah, we didn't use it. We hand sutured it. So. That's basically what anastomosis is. For this surgery, does the patient also have to wait a week before he can eat? Not really a week. Actually, 4 days. Around 4 days is like the golden period. Okay? Because what we don't like to happen is, if you feed the patient too early, it might, and the patient's really, not in good condition to eat, it might break the anastomosis or the connection. And that, here it is. Anastomotic leak. This is something we do not want to happen. Okay? Anastomotic leak is when when your suture breaks open and everything leaks out. This is when this happens and the patient starts complaining of pain, fever, vital signs are unstable. That means the patient has to go back inside the operating room again, and you have to fix this. Usually, when you fix it, you have to like cut this out again and redo another anastomosis. Okay, so that's the thing. That's what's bad. That's why we don't really feed them right away. Okay, we wait a few days before feeding them. Wait, I'm new. Is he an actual surgeon? Yes, I am. I'm a surgeon in real life also. I'm a surgeon. I'm a rogue surgeon VTuber, and I'm also a surgeon in real life. Anong diet ng patient after surgery? Nothing per orem. NPO. Right after surgery, I don't feed them. Not yet. I wait for a few days. And then I just feel the abdomen, I check their vital signs if they're good, then we slowly start feeding them. Like, we start with water, and then after water, like, general liquids like soup, juice, that, milk, and after general liquid is soft diet, so yung mga lugaw, bread, until they go to a regular diet. So pinafast, yeah, I have to. They can't eat. I don't want to end up with something like this, okay? This shit's a nightmare. I'm telling you guys, this shit's a nightmare. If the anastomosis breaks and you have a leak, that's a nightmare. And I don't want that to happen. It means the patient suffers more because he'd have to go back inside the operating room. So, yeah. Here, let's go back to our... Okay. So, after that, we closed up the patient. We washed his insides because, he had a disgusting necrotic bowels inside his abdomen, so we had to clean that up. We had to clean up all the nasty shit inside. Wash, put a drain, and then we good. Okay? And then, so ang nutrition lang ng patient is through IV. Yes! This patient is on TPN, or Total Parenteral Nutrition. He is on TPN through IV. Okay, so, I think he's been on TPN for the past 3 days. He's still in the ICU. This patient's still in the ICU. He's still recovering. Okay, he's not fully recovered yet because his condition was actually so bad. His condition was actually so bad because of this thing that happened to him, the volvulus, the intestinal volvulus. It was so bad that he was septic. Okay, the patient was septic. So let's go back to this. Patient was septic actually. Because right before the surgery, or more of septic shock. He was in septic shock actually. Septic shock is a very deadly state of the body. Septic shock is when you have a known source of infection. Okay, you have infection. And it spreads all over. It spreads. And it affects your other organs. So, for this patient, he came in with really bad vital signs like, like I said, 80/60, 80/40, blood pressure. His heart rate was like 150s. His breathing was bad. He was like breathing 40 breaths per minute. The normal is like 20. He had fever. And like I said, when we inserted a Foley catheter, he only had like 50 milliliters of urine. And it was concentrated. It was like dark orange or dark, like almost looked like tea. Looked like the color of C2. So, he had a kidney injury already due to the septic shock. This septic shock starts affecting other organs, okay? And you can see it a lot in kidneys. So, he really needed emergency surgery. If he did not undergo this surgery as soon as he did, this patient would have died. Like, really quick. It would be very quick. So we were able to remove this. We removed the source of his infection. We fixed his bowels. He's in the ICU. He's awake. He's actually more calm now. Hindi siya matapa. He's more calm. He is he's more understanding of his condition, basically. Because I talked to him like, you better behave, man. I am trying to heal you. I am trying to help you get better, so you better behave. Okay. He still has some signs of septic shock. So his urine is right now improving, but he still has signs of kidney injury. So his serum creatinine, the creatinine is one way to know about the function of your kidneys. If it's high, that means you have kidney injury, and his is pretty high. I think if I remember correctly, he's like in the hundreds. 700. So he needs a dialysis, actually. He needs a dialysis to help him out. The dialysis is just temporary, hopefully. Okay? So he needs a dialysis. He needs that. I still cannot feed him because he still has the NGT, and there's still a lot of fluid coming out. There's a lot. So his body's still trying to recover. But so far he's looking good. Like, he's awake, and he's not... His blood pressure's better, his heart rate is going down. So, he's overall slowly getting better. And hopefully it continues on. And I don't think this patient's gonna be discharged before Christmas. I'm pretty sure he's gonna be spending Christmas in the hospital. I hope that he can go home before New Year's. But it really depends. Because, he's still in recovery. I can't send him home just yet. But so far, since the surgery, he's slowly getting better. Okay? His vital signs are improving a lot. If before surgery his vital signs were like where is it? Here we go. If his vital signs before surgery were like this, okay? Right now, his vital signs are like 120 over like 80, and then his heart rate is now at like 108 to 109. 108 to 109. Potato Dino, thank you for subscribing. His his respiratory rate is like in the 24. It's still high, but it's better. He still gets fever from time to time, so you know there's still something. We still gotta watch him. Okay, he's doing a lot better. He's still not quite there yet, but he's definitely much better than before the surgery. Okay, sepsis sucks. Yes. Tatayo pa nga para Hope it's soon. It'd be sad spending both Christmas and New Year in the hospital. Yeah, I know, right? We have a few patients who might be spending Christmas. Okay, so yeah, that one. This guy is this one is this is an intestinal volvulus. Volvulus is basically when they twist around on each other. That is this case, so this is him. I actually had another case of volvulus before this one, but this one, okay, I'm gonna tell you another case. We'll go briefly through the other case, okay, because it is 10:27 and I don't want to make my medical education streams too long. I had another case of volvulus, but this one was a girl. So I think she's like, let's say patient name is girl. And she's like 29 years old, female. Hers was like obstruction, right? She came in complaining of abdominal pain and distension, right? Distension. And at that time, but this time, she wasn't in severe pain. Unlike the other guy, she had stable vital signs, okay? She had stable vital signs. So her vital signs were fine. Okay? Her vital signs were fine. Her abdomen was soft but distended. Okay, soft but distended. Slightly tense at the time. Slightly tense. So unlike the other guy, unlike the first guy had a rigid abdomen and it was tender all over. Okay? This girl had soft abdomen but it was distended. Her abdomen looked like a freaking balloon though. Like if she lied down, she looks like a pregnant woman. Her abdomen, like if this are her legs, her abdomen is like that. And then her body and then her head is it was really big. And like, oh my god. So she was we considered an obstruction case. She was a case of obstruction. So she was a case of complete bowel obstruction. And in the X-ray we saw it was volvulus, okay? And we were able to identify volvulus. So complete bowel obstruction, secondary to sigmoid volvulus. Sigmoid is like the last segment, the lower segment of the colon. So I'll show you what a sigmoid is. Sigmoid colon. Okay, here, this is a sigmoid colon, guys. Okay. This one. Alright. This right here is the sigmoid colon, okay? So this is the colon, this is your appendix. So this is the right side, and then over here, this is the left side. This is the sigmoid colon, okay? This is the sigmoid colon. It's near your butt. It's near your ass. Alright, this is your rectum and then sigmoid colon, this thing. Okay? So, what happens was, oops. Okay. What happened was, she had her sigmoid was redundant, okay? She had an extra long sigmoid. So what happened was the same thing. Her sigmoid twisted, her sigmoid twisted around because of an adhesion. So this is her rectum. Her sigmoid twisted around like that. Freaking. Oh. Twisted. Yeah. Her freaking sigmoid twisted around like that, okay? And there's like adhesions here. Freaking adhesions right here. Okay, it's the same thing. Yes, it can. It can. How does it happen? The same thing as before. There was adhesion that caused it, okay? But, there's a big but. The difference between her and the other guy is we were able to rectify this. We were able to temporize her. Like, she was supposed to go for emergency surgery. But I was able to prevent that from happening and converted her to an elective surgery instead of an emergency surgery. What you do is you put a rectal tube inside. So, you put a tube inside her butt. You put a tube inside her butt, right? It's like one of those, first aids or something. You put a tube, you get a tube, you put the tube inside, okay, like a straight tube. What happens is, if the tube is firm enough, the tube is gonna go and, put the tube until it crosses through this. And then this tube, whatever's in here, whatever's in this intestine will go out through the tube, okay? So all the shit and the air, they go out through the tube, outside. Okay? And, what happens is, sometimes the tube can untwist this. So what happens is, if you put the tube in, her intestine would look like, this is rectum, okay. Oops. You would untwist it. Right? You put the tube in, you put the tube in, you basically untwist it. You basically untwist it, okay? So whatever, you drain it, and then it helps untwist it. So we were able to untwist her volvulus with the tube. So instead of operating on her as an emergency, we were able to operate her electively. So we were able to prepare her properly for a surgery. Brute force, man. It wasn't really brute force, but I just slowly put the tube in. So that's the difference. Shiori-sama, hello corpse, hello. You just poke it, now you just put the tube inside. Like 25 cm of tube inside her butt. And we were able to, she stabilized her. She was feeling better when she had the tube in her butt. She felt a lot better. Okay, parang host na bit. Yeah, she actually felt a lot better, and we were just like, okay, you're not for emergency surgery anymore. Okay, so we were able to temporize, we were able to untwist it, but you need surgery. You still need surgery, okay? You still need surgery because these things, sigmoid volvulus, they tend to happen again. Because, for example, she had a redundant sigmoid. When you say a redundant sigmoid, her sigmoid is a lot longer than usual. So usually those kinds of things, when you have an extra long sigmoid colon, they do tend to twist around. So hers was her sigmoid colon was reaching like the other side of her abdomen. Like, I'll show you. If this is how a regular sigmoid colon looks like, this one right here, like this, right? This one over here is the right side of the abdomen. This is her butt, okay? Right side of the abdomen, left, and then it goes here into the center. This is the sigmoid colon, right? Her sigmoid colon was extra long, so imagine this extending all the way up to here. It would go like that, like a little S. It would go like this. So it's extra long, so they just tend to like loop around, whatever. Loop around and twist on itself. That's a redundant sigmoid. So if you have that, you have a tendency to develop a sigmoid volvulus. Okay. So the surgery for that sigmoid volvulus, whether or not it's emergency or elective, in her case elective, you have to remove the sigmoid. You have to reduce that. You have to take out the sigmoid. So that's what we did. And her sigmoid, unlike the surgery of the other guy, where his intestine was freaking black, hers was like a really dilated sigmoid. Her sigmoid was pretty fat and dilated. How do we avoid happening on ourselves? Sigmoid, you can't. If you're born with it, you're born with it. You'll just find out. If you're born with a long sigmoid, you're born with a long sigmoid. Okay? So, she is also recovering right now. So, this guy and this girl actually had the surgery at the same time. Well, not at the same time, on the same day. Hers was elective and the other guy was emergency. So, she's recovering. Actually, she's right now starting to drink water. I already started her on water because she's doing fine. So, if she is able to eat normally, I might be able to send her home on Christmas Eve. Okay, she might recover a lot. She will recover a lot faster. Okay. Pag ba't matagal tumae, mahaba yung sigmoid? Constipation can be a sign of a long sigmoid. It can be, but it doesn't mean it is. There's many causes of constipation. Don't people in Asian countries tend to have longer intestines? It doesn't mean you have a redundant sigmoid. You can have like longer small intestines, or generally longer, but if your sigmoid colon is longer than usual, then the ratio that is given here, then you have a redundant sigmoid. DNA gotcha. Yeah, you're just born with it. Just get it, and then yeah, that's it. Yeah, there's many causes of constipation. So. So yeah, I hope you guys wait. Can I like zoom out of this? Look at my notes. My notes, man. Look at that. Wait, look at my notes. I zoomed out on my notes, and this is what it looks like. Look at that. So yeah, that's it for tonight. That is the medical education for tonight. Okay. Oh, okay. Let's do this. Let's take this out. There we go. Alright! Nakaihi na ba si Idol na patayo? Nah, he's still lying down. He has a Foley catheter. So, yeah, I hope you guys could learn a lot. Walang quiz? Okay, since you asked for a quiz, alright, let's go. Let's do the quiz. You guys asked for it. You guys asked for a quiz, so I will give you a quiz. Okay. Let me open up the... Okay, we're gonna do quiz. You guys asked for it, okay? You guys asked for a quiz. Sinong nagtanong? Tagal na di ko kayo kinwiz, no? I have not given you guys a quiz in a long time, so we will give you a quiz today. Okay. Alright. Prepare 1/4 sheet of paper. 1/4 sheet of paper. Okay. Tapos, wrong spelling wrong. Wrong spelling wrong, ha? Okay, we're gonna... What do I use? Okay. Oh. Oops. Okay, guys. Let's use this one. 1/4 sheet of paper. 1/4. Wrong spelling wrong. Okay, yeah. Okay, 5 questions. Number 1. Okay, number 1. Hey. Number 1. Pwede gumamit ng chat GPT. Hoy, no cheating. No cheating. Okay, number 1, spell mo ang volvulus. Anong spelling ng volvulus? Oh, ito yung spelling ng volvulus. Oh, yun na. May clue na, ilang letters. Volvulus. O, Pocari says Pocari says V-O-L-V. Mali si Pocari. Okay, mali. May mga mali ang sagot. I picked number C. Okay. Popmaster got it right. Anong bulbul? Hi! Hi! Dahil dyan, Popmaster, hindi counted yung sagot mong una. Kung ano pinagsasabi mo. Whatever you say. Wala! Popmaster, wala. Labas! Labas si Popmaster. Labas! Okay, number 2. Wala na disqualified pa. Okay, Popmaster. Okay, mga bumagsak. All those who failed, Popmaster. F for Popmaster. Si Popmaster. Okay, Popmaster failed. Failed na. Okay. Okay, so... Alright, number 2. Number 2. Let's go. Okay, number 2. What do you call the fat what do you call the policeman of the sinabi ko, policeman of the abdomen, the fat that is like the policeman of the abdomen, policeman of the abdomen. Sinabi ko nga yung sagot kanina. I said the answer a while ago. Oh god. Tubig muna. May tubig naman ako. I have water here. Don't worry about it. Lymph nodes. What lymph nodes? I call it Pedro. Pedro! Okay. Taco got it right. Aumento! At least we got some people who are listening. First name na yun. Okay, next. Ano ba? I don't know what it was. Oh, okay. Okay. I think I mentioned it, but I never said it. Okay. What does NGT stand for? Number 3, NGT. What does NGT stand for? NGT. Blank tube. What does NGT stand for? Neon Genesis Evangelio na tayo. No going to toilet. No. Nasogastric tune? Bakit tune? Why tune? You almost got it right. But no, it's not. No girlfriend time. Bruh. Okay. Alright, so how do you, So for NGT, where do you insert it? Where do you insert it so that it goes to the stomach? Where? Rectum. Oh, grabe naman kung rectum yan. Ano yan? Rectum tapos hanggang stomach. Yan, ang haba-haba naman nun. Wet papuntang stomach. Wet hanggang stomach. But for babies, the mouth. Yeah, if it's babies, they call it an OGT. Because an NGT is a nasogastric tube. If it's OGT, it's an oral gastric tube. Oral gastric tube. Nose. Okay, people got it right. Okay, number 5. Last question, boys. Last question. Oh my god, I'm coughing. I dropped my pen. Okay. Last question. Sure. Okay, last question. Last question. Sino ang pinakamagandang Dr. VTuber sa Pilipinas? Sino ang pinakamagandang Dr. VTuber sa Pilipinas? Bonus question. Bonus. Who is the prettiest Dr. VTuber in the Philippines? Ako. Vicky Bello. Tayo, VTuber ba si Vicky Bello? VTuber ba si Vicky Bello? Si Doc Ryan. Maganda ba si Doc? Maganda ba yung si Ryan? Doc Willie O. Doc siya. Excuse me. Oh God. Wait. I'm gonna drink water. Doc Willie O. Ba't si Willie O? Ang babuist niya. Si mashed potato lang pumasa. Mga hayop kayo, bagsak kayong lahat. Tangina nyo. Yung standy dito. Standy yung maganda. Lahat kayo bagsak except si mashed potato lang yung mashed potato lang pasado. So, A plus si mashed potato. Mashed potato para O8. O, A plus. Okay, siya lang pumasa. Wala, bagsak kayong lahat. Buisit kayo. Hayop kayong lahat. Okay. I think we're good for tonight. We've been, the stream has been going for 1 hour 48. Anong sabi ni Lord Bad Baglay? Leche ka! Okay. Thank you guys for watching my stream. This is the last medical education stream for the year. Okay? At least di pa after. Excuse me! Kayo yung nag-request ng pa ako! Hayop kayo! Kayo yung nag-request nun! Tangina nyo! Yeah, Otsupon. Okay, Otsupon, guys! Thank you for coming to my stream. I hope you guys learned a lot. I didn't really prepare any slides for this, but I used MS Paint to draw, and then we just Googled stuff. I hope you guys learned stuff here, okay? I really want to do medical education streams in 3D, but then I don't have the means to. Like, I was thinking of doing medical education streams on, like, VR chat. If I have my own world in VR chat where I can do, like, medical education stuff there, that would be really cool. I would have, like, full body tracking, VR, and then teach you stuff there. That would be really cool. Okay, I learned not to trust my intestines. Yeah, take care of your gut, guys. Take care of your intestines. Eat well. Laging uminom ng Yakult. Hey, Yakult's pretty good. Yakult's good for you. Okay. Alright, guys. Thank you, Atsupas. I was gonna say let's raid someone, but I don't have... I don't know how to use the raid feature here anyway, so whatever. Sasabihin ko raid. Wala palang raid on YouTube. It's redirect, but I don't know how to use it. Thank you for coming to my stream. It's fun. I'll see you guys next time. I might change my stream schedule. I think I had a schedule on a Sunday. Yeah, Sunday. I had a stream schedule on Sunday, I think, but I might not be able to stream on Sunday. I might not. Okay, I might have to move that. So yeah, it's fun. Thank you, everyone. Teka. Yeah, look, see. Sunday I'm supposed to do Ace Attorney, but I don't think I'll be able to. Yeah, I don't think I'll be able to. I'll see. Okay, we'll see. I'll just make an announcement. Right. Atsupan! Okay, guys. Bye-bye! Atsu! Thank you!